Good evening, everyone. On behalf of Intas Pharmaceutical Limited and Zenith Division, I, Dr. Mithilesh Nayak, welcome you all to this 10th episode of webinar series Endocrine Talk Show. And today we are going to discuss about one of the most important aspects, that how kidney play an important role in managing various metabolic aspects with regards to endocrinology. And to provide more insight on the topic and to guide us today, we are having with us our course director for the program, who is continuously guiding us in conducting this webinar series, Dr. Subhankar Chaudhary, sir. He is one of the most trusted endocrinologists of India and currently professor and head at Department of Endocrinology, SSKM Hospital, Kolkata. So with this word, I hand over this digital podium to Subhankar Chaudhary, sir, and request him to introduce our panelists for today's program. Over to you, sir.
Thank you very much. Very good evening, all of you, all across the country. It's been a wonderful journey, interacting with so many of you on different aspects of endocrinology. So this evening, we thought we know of different classic endocrine organs: the pituitary, the thyroid, parathyroid, gonads, pancreas, so on and so forth. But whether the kidneys should also be considered an endocrine organ and what are the implications, that's what we shall discuss this evening. And to take us through this chit-chat sort of program, we have, as usual, very eminent faculty from all across India. Though formally we have done away with the Maharajas, I think we have the kings in the field of endocrinology from different parts of India joining us on this program. And we have Dr. Bipin Sethi, who is consultant endocrinologist with Care Hospital in Hyderabad, one of the kings in this field, and a very well-known speaker and clinician, and a very good friend of mine as well. We also have we got we have Professor C.V. Harinarayan. I hope he is joined. He will be joining anyway soon, who actually headed the Department of Endocrinology at the SVIMS at Tirupati, but currently he's Director of Endocrinology, Diabetes, Thyroid and Osteoporosis Disorders at the Sakra World Hospitals in Bangalore. And he has done a lot of seminal work in relation to vitamin D metabolism in our country. We have with us this evening Dr. Rishi Shukla, who heads the Department of Endocrinology at Regency Hospital in Kanpur, and also Chief Consultant at Center for Diabetes and Endocrine Diseases in Kanpur. Again, a very well-known face and a much sought-after speaker at different conferences. And we also have Dr. Hemant Patale, who is consultant endocrinologist and diabetologist at Samrat Endocrine Institute at Aurangabad, has been practicing since 1996. So welcome all our faculty, welcome all our participants. Especially for the participants, please put down your questions, and these will be passed to me in the chat box by Dr. Mithilesh. And by the time we get some questions, maybe we will start the chat talk show going. And so one of the first questions, of course, would be to try and understand why at all should we consider the kidneys. They are important in their own right, but do they also have some endocrine role to play? And to take this very important issue forward, can we ask Dr. Bipin Sethi to throw some light?
Thank you. I think it's an appropriate question to kickstart the session. We are aware that kidneys are usually looked upon as organs that cleanse the body of the useless material, maintain the salt and water and electrolyte balance. But truly, through their actions, they do produce some hormones. The main hormones that they produce are renin, which actually is something which regulates the kidneys' blood flow and maintains the renal blood flow. So that is something which is purpose of renin is to generate through angiotensin vasoconstriction and aldosterone, which retains salt and water. So it is a servo check mechanism of the kidney to ensure that it gets some blood at all the times. Then it is a powerhouse, and like all powerhouses, it has social responsibilities. And it then produces erythropoietin, which is produced from the fibroblasts in the cortex, and that maintains the hemoglobin concentration with its attendant better tissue perfusion or tissue oxygenation. Through its 1-alpha activity in the proximal tubule, it also participates in the vitamin D metabolism by producing an activated form of 125 vitamin D, which is considered a hormone. And therefore, these are the three main actions by which kidney can be considered as a hormone-producing organ, so an endocrine organ. It produces also urodilantin. It also produces adrenomedulin, which are minor, and they are not the only ones which regulate, say, the natriuresis. The adrenomedulin acts on the inner collecting system and acts on the tubules to sort of cause natriuresis. The adrenomedulin has got anti-proliferative properties. It also causes vasodilatation. So there are minor hormones, but the major hormones that it produces are renin, and the entire RAS system is dependent, so to say, on the kidney. And it has an action on producing erythropoietin and certain other substances like uromodulin or adrenomodulin, and activated vitamin D, which Ali will be talking about in greater detail.
Right. So those are, of course, I mean, those would lay the claims of the kidneys also to be endocrine organs. But beyond this, on a practical level, do you think the kidneys have also important role maybe in degradation of insulin? I mean, which will have endocrine implications, but not as an endocrine organ.
So if you look at it that way, then the kidneys are responsible for the actions of certain hormones, which would not be, seriously speaking, endocrine action. They also produce, for instance, they are important in glucose homeostasis by producing gluconeogenesis. But strictly speaking, that would not be a substance that is produced by the kidney acting at sites other than its action. So I was talking about hormones that are produced by the kidney, and that which qualifies it for as an endocrine organ. As an endocrine regulator, certainly it will be responsible for a breakdown of insulin and many other things. So that was something which I did not deal with.
Yeah, of course. Good. So the three main sort of hormone actions that you mentioned were in relation to renin, and then erythropoietin, and then calcitriol or 125 dihydroxycholecalciferol. So let's take one by one each of these, and in the meantime, if we have questions from our audience, we shall of course address them to you. So coming to the
Shankar, can I interrupt you in a minute? A question is in my mind. I wanted all wise people are sitting, Dr. Sethi and you and Dr. Hemant. You very nicely mentioned the endocrine function of a kidney. Where is the role of endocrinologist in all of them? I was just giving a thought. I thought I can get some answer from.
Right. So endocrinologists will more conventionally would be involved if there is derangement of kidney function, and then of course whether the question maybe whether it's a primary role of the endocrinologist or it's a role of the nephrologist. I think, by and large, and if that's what you are trying to point out, by and large, the nephrologist manages those issues rather than taking the help of the endocrinologist. But maybe this is a talk show that will help people also to change their perceptions. But yeah, Dr. Sethi and Dr. Hemant, your observations.
I think the renal osteodystrophy or maybe secondary hyperpara SHPT is endocrinologist has some role in it. Though as Dr. Shubhankar Chaudhary was telling us, that is the CKD usually managed by the nephrologist, but I think endocrinologist can manage more perfect than sometimes it is happen that it is a autonomous city is for secondary to autonomous city might happen, and that is where comes the role of endocrinologist. Besides that, there is a because of nutritionally poor in CKD population, as Dr. Chaudhary was talking about, is the insulin resistance and then be worsening and difficult to manage with brittle diabetes also, where endocrinologist has some role in managing such populations as well.
Yes, Dr. Shetty, would you like to add?
As Dr. Shukla's questions are a little different and off tangent, the endocrinologist's role is, of course, there in managing the metabolic bone disease and the consequences of the renal dysfunction, all right? It also is important in tackling issues related to FGF23 and its dysfunction in renal disease and also without renal disease. Endocrinologists are also going to be involved, as he rightly said, in the carbohydrate metabolism derangements that impinge upon the baseline diabetes or sometimes causing hypoglycemia in people who are not having diabetes at all. So the role is quite different from the role of kidney in regulating the homeostasis by producing hormones. So I think there's a lot that people do, and in endocrine field, wherein kidney and the endocrinology interact. But we are talking about what hormones it can produce and how it could be considered a endocrine organ.
Right. And Dr. C.V. Harinaran, we haven't heard from you. So any words of wisdom from you?
Well, all the people have told. I think, can you hear me?
Yes.
All wise people have given their wisdom. So I have nothing much to add.
Okay. Fair enough. So as Dr. Sethi has already mentioned about the renin, so now we understand each or many of the organs have their own local renin-angiotensin system. So is the renal production of renin or its participation in the renin-angiotensin system so important? So if the kidneys are not functioning, if the kidneys are not there, wouldn't there be enough renin or angiotensinogen or angiotensin 1 or 2 to sustain the system? Maybe Dr. C.V., you could take that.
Yeah, the main role of renin is in the cardiovascular system, the heart failure, myocardial infarction, hypertension, vascular inflammation. Apart from all that, you have role of renin in lung disease. You would have seen the recent SARS-CoV COVID infection affecting the lung, acute lung injury in pneumonia, where the RAS activation leads on to inflammation and vascular permeability, increase due to angiotensin II, stimulation of the AT1 receptor, and thus severe acute lung damage can occur. It can also be seen that in SARS-CoV virus infection, there is an increase in the angiotensin level and the activation of AT1 receptors. This increase in the ACE level and decrease in ACE2 in SARS patient leads to increased angiotensin level and AT1 receptor expression, leading on to the cytokine storm. Now, we also have the role of RAS in neurological disorders. The Alzheimer's disease, where it has been shown primarily Alzheimer's disease is a progressive neuro disease where there is a neuropathology affecting the senile amyloid plaques in the hippocampus, amygdala, and the cortex. The amyloid beta peptide triggers the oxidation radication production in the endothelial cell and induces oxidative peroxidation and cell death. One of the main brain RAS is the angiotensin 1 to 7 peptide in a mass receptor agonist. Yes, inhibitors are also been shown to reduce the cognitive decay and the memory enhancing effect. Apart from that, it has got a role in Parkinson's disease and also multiple sclerosis. There are many more actions of the local RAS, which we will elaborate if required.
Very well explained by Dr. Harinarayan. I think I need to add something that in healthy kidney, usually in intra-renal, there is a more of from angiotensin to the angiotensin 1-7, which with the help of nephrisilin, and which has helped in which is anti-inflammatory, anti-fibrotic, and blood pressure friendly. In CKD, in fact, it is Chime's S which led to conversion into angiotensin 2 more than the less formation, less nephrisilin action, which leads to hypertrophy, which is increasing the inflammation, increasing oxidation stress, and increasing the blood pressure, which is that's what is seen in CKD especially, the decreasing nephrisilin action and Chime's S2 intrarenally because of decreased glomerular filtration GFR and rise in intrarenal renin secretion, which in turn leading to decreased nephrisilin and increased Chime's S activity, leading to more inflammation and more glomerular hypertrophy and more oxidative stress, and through increasing the blood pressure and increasing arterial stiffness and spasm.
Right, and yeah, so it's actually rather complicated system, and which part is activated at what time, possibly still we don't understand fully. Now we have already a few questions in the chat box. One is all of them are interesting. The first one by Dr. Ramakrishna, maybe I haven't understood exactly what he wants to know, why there is no order of end organ damage in diabetes patients. Means, okay, which organ is affected first is different in different individuals. What makes this difference? Would someone like to answer this difficult question?
I think this is something genetic. It has been shown for a very long time that glycemia-related complications in microvascular complications, retinopathy is almost universal. Nephropathy occurs in genetically predisposed individuals, and neuropathy is somewhere in between. Same is the case with cardiovascular disease, which of course has got input from dyslipidemia, hypertension, degree of renal impairment. As to why a person gets one and not the other, I think it's difficult to say, but there are a lot of genetic factors. If one has to go by and implicating only hyperglycemia, I think retinopathy is a classic example, wherein if person survives for long enough with bad disease, retinopathy is universal. Nephropathy doesn't happen to all the people. So it's not clear why some people get this first or that first. But there are factors other than glycemia that regulate, and they are not just metabolic, but hemodynamic factors for nephropathy, genetic factors, and for cardiovascular disease, many other factors. That's
absolutely. Yeah, so that's where we have got Dr. Shetty on our team to make things simple. So there's another question, Dr. Omkar Singh, who is asking about a young patient, 26-year-old, who has demonstrated sugar, glucose in the urine several times. A1C is 5.7, has not ever received any medication. So what are we? What should we do? What is the condition? Maybe Dr. Rishi Shukla, if you'd like to answer.
Yeah. So, thank you. Thank you for the opportunity, Intas, Amit, and everybody. And I think the answer is the renal threshold varies Normally, after 180 milligram, the urine starts passing from the urine. Or if patient is not taking any medicine, because now SGLT2 inhibitors are also approved for various non-diabetic conditions. But apart from that, usually the sugar in urine appears when it crosses the threshold of 180. But this threshold varies from person to person. In some people, it may be 160, 140. So many times it is normally present. So I think this is one condition which we commonly see in day-to-day practice. And if blood sugars are normal, probably we need not do much. And any addition, I think you're welcome.
Right. So what renal problem we should suspect and what's the right approach? Of course, if it's only glucose that's passing, not other things that are also leaking, then I think it's a relatively benign condition and people have been observed for years together and have not been found to suffer from it. Only one needs to sort of have this masterly inactivity possibly is better. And now maybe Dr. Hemant. So Dr. Oza wants to know, he's got a patient with resistant hypertension. So in the city of Aurangabad. And so whether he should be referring to you or to the nephrologist for further, if routine investigations are normal, who should he refer the patient to?
Yeah, the very well you are talking about this. The patient is 26-year-old, and then we need to examine the patients clinically to take a call upon. If patient is having the fluid retention, and if the renal parameters are deranged, then possibly we are dealing with a renovascular. But the patient is young patient who is having uncontrolled hypertension on routine antihypertensives. And in addition to that, if there is a clinical examination which might suggest like multiple endocrine neoplasia or maybe like a lot of capillate spats, then you may be having signs of Cushing's, maybe signs of hyperthyroidisms, and maybe a genetic history like family history of hypertension, maybe essential hypertension runs into it. And most important part of it is a BMI, whether he's obese and strong family history of hypertension. It may be a simple systemic hypertension also, which might control on routine one single antihypertensive agents. If this patient doesn't control maybe a 2 or 3 hypertensions and there are episodes of hypertensive crises, or maybe all the times will be very high, like maybe 160, 170, 180, even with 2 or 3 hypertensive, it's warrant investigations for maybe to not pheochromocytoma. If this patient has a proximal muscle weakness or hypokalemia like history, then might be dealing with an hyperaldosteronism. So clinical examination and proper family history will definitely guide us where we are going to head it.
Right. So if the
can I add one line,
yeah.
Dr.
Yes.
I think that there was a series, 2-3 series of publication from AIMS, and they have shown that primary hyperaldosteronism is a primary or secondary both is one of the common causes of refractory hypertension, and that we often miss. So we should also look into that. And normally in Conn's syndrome, we see hypokalemia, which is not seen in real life patients. So if patient is more than 3 antihypertensives, relatively younger, we should go for plasma renin activity, which is quite helpful. And once it is positive, the PRR plasma renin ratio, then I think we should work up for any causes. And if we don't get any, then we put patient under primary hypertension and we treat intensively.
Right. Yeah. Okay.
Yes.
And
said
so
almost 5 to 10% of the hypertensives are having primary hyperaldosteronism.
Yeah, that's what
Correct.
many studies suggest, but I don't know whether in clinical practice, of course, we don't look for it that attentively or aggressively. It does not appear so in routine clinical practice, but of course, in resistant hypertension, yes, there will be significant numbers. And sure, endocrinologists have a definite role there. If we come back to the normal kidney, sort of, Dr. Rishi, how important is a kidney in normal erythropoiesis? In renal failure, we know there is anemia because of loss of erythropoietin, but is the erythropoietin the primary main driver of erythropoiesis?
I think this is a very important question, because erythropoietin is produced by the cortex near medulla, and pericytes are the cells which have a very unique character of sensing hypoxia. No cells in the body sense hypoxia. And in response to that, they also have capacity to produce erythropoietin. So whenever the hypoxia is there, whatever is the mode, it generates erythropoietin. And when it increases the erythropoiesis, increases the red blood cells, so oxygen carrying capacity, and then when it reaches to endpoint, that it gives a negative feedback to pericytes. So this is the way it works, because this is the very common observation that in COPD, those who are hypoxic, they have more secretion of erythropoietin by virtue of hypoxia. Hypoxia is occurring in the lung, but it is stimulating kidney to produce more erythrocytes. Smokers also have a higher hemoglobin because of the same reason. So this plays a very important role. But in failing kidney, especially in the chronic kidney failure, there is initial stimulation, but later, since the parenchymal part is not functioning as well, so erythropoietin secretion eventually goes down. So it is no longer in a state to support. That's why majority of renal patients in later part become anemic. And to supplement that, we give erythropoietin from outside. So it is a very, it has a very important role in day-to-day practice. Like in runners also, there is hypoxia and it stimulates erythropoietin. Yes.
Right. So Dr. Oza, continuing with his concern with resistant hypertension, has another question: why MRAs, mineralocorticoid receptor antagonists, underused in resistant hypertension? Maybe a flippant answer would be maybe because endocrinologists are not so much involved in management of resistant hypertension. But Dr. Bipin Sethi, how would you respond to that?
That's a very relevant question, because even guidelines do not indicate the use of mineralocorticoid receptor antagonists, for one reason, that people are afraid of hyperkalemia. And the classic substance that we use, that is spironolactone, can produce gynecomastia, can produce menstrual irregularities in women. So unless there is a specific indication, people don't use this. But he has a point that it is important, just like we say that diuretic must be in the chart of a patient before we say he has resistant hypertension. I think given that about 10 or more than 10% of so-called essential hypertension are having primary hypertensionism, this drug can be administered before saying that the person is resistant. And there is definite underusage, but you must use it carefully because it can cause hyperkalemia. You should look at the renal function. Many of these people have renal impairment, but certainly one can use this, and if not, one can use eplerenone. The new drug that is there does not have good antihypertensive activity, eplerenone. It is good for proteinuria kidney disease, but it is not a good antihypertensive agent. So if you have a case, you should carefully and cautiously administer mineralocorticoid receptor antagonist to people with resistant hypertension. As Dr. Shubhankar said, it's not necessary and it's not very difficult to investigate patients for primary aldo. Dr. Shukla said that we will show that renin is low and aldosterone is high. After that, we have to show that renin is the aldosterone is suppressible or not with a saline load of glucocortisone. After that, we have to do an imaging to show that there is a problem. And then we have to do a venous sampling to show which side is secreting. So it is a very difficult kind of a workup. And most people do not follow this pathway because it is very expensive, not just in our country, but also in other countries like United States. It is not that all patients go through this pathway of A, showing aldosterone elevation with suppressor, in B, confirming that it is indeed elevated, trying to localize, and then doing venous sampling. It's a very difficult circuitous path. That's why many people don't investigate. But you have a point. We need to treat and look for hyperaldosteronism more than we are already doing.
Right.
I think just want to add a real life issue into this. What happens? We see hypertensive and diabetics quite frequently, and they are very frequent combination. And we have triple combinations available, which we write very frequently. So once it is not controlled, we add one or two more, and eventually after 5 salts, 4 salts, it is controlled. So here we probably miss the number of patients who are having primary or secondary hypertension, because primary hyperaldosteronism because of primary reason, if we don't find a cause, or if there is some tumor. Because Dr. Rajesh Khatgawat, I think he had a very nice presentation on this, and I heard, and he has nice publication. And Dr. Harinarayan was saying that 5 to 10%, he showed the same amount of data. Problem is, we are using antihypertensive 3, 4, 5, and eventually we are able to control, and then we forget. So in this process, number of patients we are missing. This is what
True.
I want to
Yeah.
add.
Yeah, true. Should uncover treatable causes as far as possible. So we come to the other part of the endocrine story of the kidneys, namely the production of the active form of vitamin D. So, and since we have got a vitamin D man amidst us, Dr. C.V. Harinaran, why not ask him about, so we know that the kidneys convert the 25 hydroxy to 125 hydroxy, and that's supposed to be the active form. So does cholecalciferol itself, or 25 hydroxycholecalciferol, do they not have any biological activity, Dr. Harinaran? You're muted. Dr. Harinaran.
Can you hear me?
Yeah. Yes, now, yes.
When you're talking about the osseous effects, yes, 125T3 is the most active form of vitamin, the osseous effects. Even for the non-osseous effects, majority of the effects is only by the active form. Very little effect is there, if any, by the cholecalciferol. It's more the storage form.
Right. And we have Dr. Chauhan asking you, what's the link between vitamin D and immune function of the body? Dr. Harinaran, vitamin D and immune function, and as a corollary, he talks about infection in patients who are diabetics and having low vitamin D compared to those diabetics with normal vitamin D.
Off the cuff, I may not be able to give you much information, but then it is supposed to be very helpful in the helper cell formation. And also, it is also help in tuberculosis, one in the treatment as well as in the prevention also. Conversely, majority of the patients whom you see with tuberculosis, even in the upper socioeconomic strata, if you look at their vitamin D levels, they are very low. Coming to the other portion, immune system effects have got plenty. Even in type 1 diabetes, it's supposed to have an effect. It is supposed to have an effect in multiple sclerosis. Very high doses have been tried to the extent of even 60,000 units per day. So these are all in the experimental work stages. But whenever we talk about vitamin D, it's primarily about the osseous effects and not the non-osseous.
Right.
Can I add something?
Yes, Hemant.
See, we have vitamin D and the receptor. And the receptor is for 25 OHD receptor and 125 receptor.
Right.
125 receptor is metabolically active. It is helpful in minute-to-minute homeostasis maintenance of parathyroid and hour-to-hour as well. But there is a receptor which is 25 OHD receptor, which is important, has a renoprotective action even in CKD in the absence of low calcitriol levels. If you improve the calcitriol levels, still especially the soft tissue rheumatism, Debian has immunity, which you are talking about, which has action through it. Secondly, it is also act on a megalin, which is produced by the renal tubular cells, and which is in fact has a role in a reabsorption of 25 OHD in a intact, normal functioning kidney as well. So the cholecalciferol and 25-OHD cholecalciferol has both has an action on 25-OHD receptor gene as well. So it is something which is different than 125. 125 has a role through the metabolic calcium, parathyroid, and the bone metabolic part of it. But the soft tissue rheumatism, immunity, and these are through the 25-OHD and the cholecalciferol, which is acting on a 25-OHD, which also has a renoprotective role besides 125 gene receptors.
Yeah, but the primary receptor is, I think, is acted upon by, when we talk of vitamin D receptor, I think primarily it's acted upon by the 125 dihydroxy D, as Dr. C.V. and Harinarayan said, isn't it?
Yes. See, whenever we talk about vitamin D actions, it is not complete without calcium. Majority of us are also deficient in calcium. For example, if you want to look at the osseous effects of vitamin D, without your calcium, pure vitamin D will never lead on to calcification of the bone. Similarly, at the subcellular level, for example, release of insulin requires calcium, intracellular calcium. So unless you give calcium along with vitamin D, you will never find the improvement of the non-osseous cell.
Do I agree part of the calcium and homeostatic part of it? Rest, there is something like 25-OHD gene and G receptor does exist and has some role.
Agreed. Agreed. But the majority of the action is by 125D.
Fine. So I'll ask Dr. Harinarayan another question. So in an average patient of vitamin D deficiency, if we measured 125 dihydroxyvitamin D, what would be the level be like?
125 D3 level would be very almost normal, because
so if it is normal, yes. So if it is normal, and if that is the hormone that we are concerned with, then why bother about vitamin D deficiency?
Because
don't give them vitamin D.
There.
So, but still, your vitamin 125 form is normal.
It will be the lower limit of normal.
Lower limit of normal. Okay.
Yeah, you will never have. You will never have a. You will never have a normal level of 125 D3. Come on, let's look for example, people who undetectable vitamin D level, 25 hydroxy. Do they come to you with tetany? No.
Commonly, no.
No, that's it.
Right. So we looked at renin, we looked at erythropoietin, we looked at vitamin D as different endocrine functions of the kidneys. Now let us try and understand how different systemic disease could affect the endocrine function of the kidneys. Dr. Bipin Sethi.
Thank you. See, if you are looking at endocrine function of the kidney only in terms of the three major hormones that we had just enunciated, renal disease in and by itself can impair many of these functions, chiefly erythropoietin production. It can also impair the 125 dihydroxyvitamin D formation, and it can lead to local and systemic effects of renin-angiotensin system overactivity. That is something which is very well known in patients with renal disease. However, if you are looking at renin synthesis in patients with hepatic dysfunction, in cardiac dysfunction, most of it is on account of decreased renal perfusion, which then activates the macula densa, and then you get renin. And this renin is basically trying to increase the intravascular volume through the actions that it has via angiotensin on generation of aldosterone, and also make whatever intravascular volume is there apparent by vasoconstriction. It also increases the thirst mechanism. So basically, all these mechanisms, whenever there is decreased intravascular volume, the kidney is trying to help the body retain more water or increase the tone of the vessels so that the perfusion to critical organs, including heart, brain, etc., is maintained. Major impact of all these diseases is through renin-angiotensin activation. Of course, whenever there is volume expansion, whenever there is increased intravenous pressure in the inferior vena cava, it's directly transmitted to the renal veins. That also impairs the renal filtration at the level of the glomerulus. So you have most of the systemic diseases impinging upon the renal function through the renin-angiotensin mechanisms. And answering one question which you asked earlier, for normal physiology, renin-angiotensin-aldosterone axis is important for its systemic effects. But individual organs have their own renin-angiotensin systems, which can then lead to defective cardiac remodeling, can cause vascular changes, and can cause problems in the brain. So when we talk about the renin-angiotensin system in the sense of the term that all of us know it, it is purely a volume and salt-related activity, and kidneys function, if I can recollect Professor DiFranzo, he says that when God sent kidneys to the earth, he told kidneys, do not lose salt. The main role of kidneys is to somehow retain salt. And all systemic diseases impinge upon the renin production through this intravascular volume depletion. And renal structural damage, whether it is because of diabetes causing increased absorption of glucose from the proximal tubule, causing oxidative stress, causing damage to the cells that produce erythropoietin, basically are when there is structural loss in the kidney. So CKD can impinge the hormone production and cause hormone oversecretion of the RAS activity. And systemic diseases largely impinge on kidneys and make the RAS system overactive. That's why we have the activated system. Whenever we try to suppress it, you do improve the outcomes, whether they are cardiac, whether they are related to hypertension, whether related to the kidneys. And the aldosterone, the inflammation and fibrosis that it produces requires mineralocorticoid receptor antagonists. And now, of course, we have drugs like finerenone, which can impinge upon that. This is what I feel that is the major part of the hormone system derangement. We have already defined which are the hormones produced by the kidney is through this volume salt axis rather than anything else.
Right. So we know availability of recombinant human erythropoietin has made a major breakthrough in management of anemia in CKD, improves quality of life, improves cognition, and so on and so forth. But in recent times, I've seen hematologists at least prescribing erythropoietin even outside of the CKD setting. As endocrinologist, would Dr. Rishi Shukla like to comment on it? So can we use this as a therapeutic agent? Because you said it's one of the most important stimulators for erythropoiesis, for any anemia, for bone marrow failure. Can we use it?
Because bone marrow failure, it is because erythropoietin, if you look at the erythropoietin level, which is normally being produced, but what I have observed in a refractory cases where they don't find any reason, and in such cases they advise and they have seen some improvement. So maybe supraphysiological doses of erythropoietin has some role in enhancing the erythropoiesis. This is what I can think.
Right. Yeah. And so, Dr. Hemant, this Dr. Oza asks you about use of angiotensin receptor blockers in type 2 diabetes patients for nephroprotection. When do you add? In whom would you add?
If you look at the guidelines as per diabetes and hypertension, any hypertensive, antihypertensive can be used to reach to the target. But whenever there is an associated proteinuria, it is the drug of choice unless it is contraindicated.
Right. And if one agent, so let's say, would you place an ARB or ACE inhibitor ahead of an SGLT2 inhibitor nowadays?
Yeah, we can use either ACE or ARB, but ARB is preferred as the study. Type 1 has a more evidence on ACE inhibitor, while type 2 has a more evidence of ARBs. But principally, both can be used, either one of them. Yes, SGLT inhibitors with some sort of sodium loss is one of the additional can be used along with, it's not the primary antihypertensive, but definitely it helps in the reduction of, to some extent, of blood pressure, and helps in the reduction of arterial stiffness as well.
Right. On top of ACE and ARB. In the background, that's a tricky question by Shubhankar sir again. That when you have somebody who is already having background ACE and ARB therapy, SGLT inhibitors on top of that has been shown to improve the renal and also cardiac outcomes. But I don't think there are any studies which have shown SGLT inhibitors alone without using ACE and ARBs. And I think that's what we were trying to allude to.
Right. So we talked about renin, we talked about
one
renin.
point I just want to add about
yes, Rishi.
Because two things to go together. I agree with Dr. Sethi. But one thing I think we all must have observed, that with SGLT2 inhibitors, the BP fall is higher compared to Western population. So many times we need to reduce antihypertensive, whatever we are using, or many times we need to even stop it. So this is
many a time. Would you say many a time or sometime?
Sometimes it's the correct. Sometimes it's the correct word. I agree.
Right. Okay.
So we are high salt eater or what?
We are. Yeah. Okay. So Dr. Rishi talks a lot about this hyperaldosteronism, primary hyperaldosteronism, where we have low renin. But what about high renin hypertension? Maybe someone, Dr. C.V. Harinarayan, would you like to take that up? Should we try and classify hypertension as being high and low renin, and then address our treatment accordingly, trying to rationalize treatment? Or just we go by the usual, the recommended approach?
It may be one of the ways of approaching the treatment. Now, majority of the treatment is taken over by the cardiologist. They decide the whole thing.
Sorry. Sorry, am I?
What's your take on that?
Sorry, I somehow couldn't hear in between because of some phone calls that came in.
No, what I said was majority of the times, whatever you said is right. Low renin hypertension, high renin hypertension. But the classification given as primary, secondary, majority of that done by the cardiologist. What would be your take on that? Classifying the whole hypertension as low renin, high renin, reclassify the whole different.
Well, if we do not have, because we remember there was the direct renin inhibitor, aliskiren, which was tried, but wasn't found to, essentially was found to have unacceptable side effects. So it was withdrawn. So unless we have specific agents which can address the high renin and different sort of agents which address low renin hypertension, I think maybe we are not doing any significant service. Yeah.
If at all we have to classify like that, for every patient we have to do renin levels. And saying the renin is very, very sensitive.
Yeah. Right. So we have a question, interesting question from Dr. Ramakrishna. Concept of reversal of diabetes with diet. Is there a possibility of renal issues over a period of time? Any impact of high protein diet? So essentially high protein on the kidneys is the concern I would feel. Whether reversal of diabetes needs a high protein diet is another issue. Dr. Bipin Sethi?
Well, I think in patients who are young, who have no essential hypertension or no renal issues, don't have any cardiac issues, it is not a problem in terms of causing any deterioration in renal function. However, if you have got background renal dysfunction, it is generally recommended that people not be given more than 0.8 to 1 gram of protein per day. In a patient who is CKD, in our population, outside this so-called diabetic reversal programs, I don't think anybody is eating proteins, including the panelists here today, to that level. But if such a patient is then given a high protein diet, 2 to 3 grams per day, then it is going to be definitely detrimental to the renal function. But in otherwise healthy people, I don't think that there is a problem, because these studies have been done in healthy individuals, and it has been found that there is no deterioration. And the important thing here is that for isocaloric diets, whether it is high protein or it is protein restricted, essentially there are no major differences in the glucose levels, in the insulin levels, in the fat parameters, if it is isocaloric. But most of these so-called reversal programs use hypocaloric, high protein diets, and the success of the program is attributed to the protein, whereas it is on account of basically the low calorie diet and protein sort of inhibiting, and ketosis also inhibiting the hunger.
Right. Yeah. So there you have your answer, Dr. Ramakrishna. And I think Dr. Rishi Shukla initiated with a question whether or how endocrinologists should be involved. So can we ask Dr. Hemant Patale as to what could be the endocrine derangements in a patient with chronic kidney disease, and where would they need the help of an endocrinologist?
Fine. Actually, the discussion in the beginning, we said that it is a kidney as an endocrine organ, and we have discussed about the kidney secreting various hormones like renin, erythropoietin, maybe 125 cholecalciferol. But kidney is also a primary target of endocrine hormones like maybe aldosterone, maybe angiotensin, atrial natriuretic factor, brain natriuretic factors. These are also plays some role. At the same time, the CKD affects the metabolic excretion of many endocrine hormones like maybe insulin, parathyroid hormone, thyroid hormones, and the sex hormones, and that leads to affecting various endocrine organs which is getting affected. Uremia, for example, may be associated with hyperprolactinemia. It does cause hyperprolactinemia. It also associated with an hypogonadism thereby. And 125, we just heard of renal osteodystrophy and various effects as well. It is also associated with the increased FGF 21 and 23 levels also in CKD populations. Low T3 is particularly important because it's a marker of prognostic marker, which is maybe associated with a bad prognosis. And anemias, which we are discussing because of erythropoietin production is less. At the same time, in the CKD, the reduced level of heptacillin, which is a marker of and the iron stores. And at the same time, they are nutritionally poor, and the appetite goes down, and the anemia is probably nutritional anemia is a contributing factors. And having said that, because of poor nutrition and low protein levels, there is a pre-receptor levels insulin resistance does exist, even in a non-diabetic populations. In diabetic population, it also does exist. So in and all, it is affecting your pituitary hyperprolactinemia, it affects hypogonadism in both the sexes. It is affecting your 125 formation and thereby the bone disease, metabolic bone disease, and then even insulin resistance also, and anemia also. So in short, to describe this entity is maybe an malnourished pro-anti-inflammatory excessive inflammations and excessive atherosclerosis, and thereby increased CV disease, atherosclerosis. So it is a malnutrition, inflammation, atherosclerosis syndrome can be put in, if you would like to put in one sentence.
Right. And of course, in a growing child with chronic kidney disease, you have significant stunting of growth by multiple factors, metabolic, electrolyte disturbances, acid-base disturbance, and so on. So,
I think one line can I add, if you permit?
Yes.
I think we are required. I mean, what I could understand, because that thought was came instantly when you were speaking in beginning. Where are we? So I think we are required, as you mentioned, the growth in children, where we need GH replacement and all. Second, I think hypogonadism or erectile dysfunction or infertility. I think these are the area probably what I can understand, that where we are definitely required. Otherwise, and the last thing Dr. Hemant told in beginning was that if the diabetes is very fluctuating or brittle diabetes, I think there we can be of help.
Right. And we have a couple of more questions and then we shall wind up. One is by Dr. Manish Sharma. Are you recommending CKD screening in patients with thyroid disorder? If yes, how frequently? Answer from maybe Dr. Rishi.
I think CKD, if you many times in routine workup, I think all of us must have experienced, we detect raised kidney, and when thyroid function was done, we used to have overt hypothyroidism, and when we treat, most of the time it is reverted back to normal. So this is a common thing. Second thing is thyroid is now a very common disorder, especially hypothyroidism. The prevalence is, I think, 8 to 9%, which is very, very high. So the kidney disease and thyroid may be very common combined factors together. Whenever we detect hypothyroidism in presence of CKD, I think if the TSH is pretty high, maybe more than 10 or 15, there should be some reversibility we expect. And if it is much more, the overt hypothyroidism is there, good amount of reversibility should be done. So I think no harm in doing once, and if it is raised, then you can follow it up. And even in CKD patient, it is better to get thyroid function test done.
I think it's a more of proteinuria and loss of protein bindings, and that's producing hypothermia, which is reversible. I think in that case, it is one of the indication for the thyroid function test in CKD or proteinuric patients.
Yeah, but the question was in patients with thyroid disorder, do you recommend CKD screening? I don't think there is any such recommendation. Nothing. Though, as you said correctly, there may be some overt hypothyroid patients who may come or have initially got a decreased EGFR or GFR, which can improve on thyroid hormone replacement. So that was one question. The other was from Dr. Dash. Which anti-diabetic agent is preferred in post-renal transplant patients with type 2 diabetes?
Dr. Dash's sawal would be answered by Dr. Sethi only.
Yeah. CARE Hospital has a strong
I will tell you a small joke before answering this question, that I saw a patient who's looking after an elderly diabetic woman who is incontinent, and she was very much distressed. So I asked her that, but nothing will convince her. So I said, this is, you are doing a holy work, you are getting punya out of it. She said, I know it, but I want to know why the other 6 daughter-in-laws are not getting that chance. So I also want to know why the other 3 panelists are not getting the chance. So as far as the renal transplant patients are concerned, not all patients are requiring insulin. If the patient's renal function is normal, they can use metformin. They can use DP4 inhibitors. And you would know that I'm trying to mention drugs that do not innately produce hypoglycemia. SGLT2 inhibitors, at this moment, there is no approval for that, because though the incidence of genital mycosis apart, urinary tract infections is almost same. One urinary tract infection or pyelonephritis in a transplanted kidney can cause problems. So SGLT2 inhibitors in transplant patients, we have to use with extreme caution, and there is no real indication at this moment. So you can go with metformin if the GFR is more than 60 usual dose, 45 to 60 half the dose, 45 to 60 also usual dose, 45 to 30 you may be cautious. And I'm not talking about immediate renal transplant, mind you, because the patient may be having many issues. when only insulin is required. DIP4 inhibitors with or without dosage modification can be used because they are efficacious across the GFR ranges. Some drugs may require dose modification, others do not require dose modification. You can also use alpha glucosidase inhibitors up to GFR of 26. GLP-1 analogs can be used up to GFR of 30 or less, but they produce nausea. And in a patient who is having some issues with intake, though they are safe, they may be very difficult to take. It's not the question of cost, it's the question of tolerance, which is an issue for about 20% patients in the initial 2 or 3, 6 to 12 weeks. If the person is requiring insulin, like any other diabetic, I think they should be given insulin. If a patient is on dialysis, even after transplant, then it becomes very difficult. But in short, the treatment depends on the renal function, and it also depends on the patient intake. How long after the transplant are you seeing him? Is he an ambulatory patient or is he an inpatient? Whenever in doubt, please use insulin and watch for hypoglycemia. Otherwise, it is not that all transplant patients should receive only insulin and no other oral drug. This is what I feel I thought I should share.
Thank you. And finally, before we wind up, can I ask Dr. C.V. Harinarayan as to his views on the use of calcitriol in clinical practice, which is very widely used by certain specialists, not much by the endocrinologists, but what are your views? When should we use? As for example, in renal failure, where calcitriol is not produced. So should we be using calcitriol only there? Is there a scope for plain vitamin D25, cholecalciferol in renal failure?
You can, because in extrarenal sites also there can be some conversion, but ideally calcitriol is the drug of choice.
And any other indication for its use apart from so? So even in other cases, why bother?
In other cases, we have seen after total thyroidectomy, they knock out the parathyroids also. You don't have a parathyroid. So at that time, when there is a parathyroid not working, so these are some of the indications.
Right. No. Let's say in any patient where you need to replace vitamin D, why not use calcitriol? Because you don't need to bother on the kidneys to convert it. You give it in a converted form.
Half-life of calcitriol is about roughly 6 to 12 hours. Whereas the storage form of vitamin D is cholecalciferol. It's about 3 to 4 weeks. So you can't give calcitriol to every patient, right?
I think, Dr. Shumakar, you have raised a very nice question, and Hari has answered that. If the 125 cannot be produced as a renal failure, if it is 1-alpha is being overwhelmed by FGF23 activity, then obviously you have to give. And when hyperparathyroidism is there, you do not have activation of this enzyme. So I think when it is inhibited by FGF23, when there's renal disease, when you don't have 1-alpha, when there's lack of parathyroid hormone, barring these situations, you are right. And Dr. Hari said that very clearly, you require a depot from which the kidney can make its own 125 in the quantities in a very well-regulated manner. Short half-life of 125 is basically something which interferes with the, and it's very expensive. So it is a useless medication for indications outside what we have said. FGF23 induced osteomalacia, renal osteodystrophy, and also primary hypoparathyroidism, whether it is pseudo or it is primary. I think these are the indications. Barring that, it is being used for quicker relief of symptoms. In fact, it will inhibit the 1-alpha of the body and prevent the formation of 125 endogenously being secreted. So this question is very relevant, that unless these 3 indications which are very, very rare, where endocrinologists have a role, certainly, there is no need to give this kind of preparation.
Thank you for elaborating on this. So I think we had a lovely discussion, and the panelists, of course, have re-established that kidneys also have very important endocrine function, and especially in presence of renal failure, there are so many endocrine disturbances that can happen. and they would require proper attention, many of which, of course, can be dealt with by the nephrologist, but it may many a time be appropriate to have the help of the endocrinologist. And we did understand especially about the role of cholecalciferol and its activation, and where actually we need to use the activated form of vitamin D. And you would be happy to know, the panelists would be happy to know, that you had more than 1,350 doctors having joined in from across the country to listen to you, to learn from you, and hopefully we have conveyed some important practical points as well. And very many thanks to all of you who have joined. Hopefully this you had whatever you were looking forward to in this evening. So it's sincere thanks to Dr. Bipin Sethi, Dr. Rishi Shukla, Dr. C.V. Harinaran, Dr. Hemant Patale, and of course to the INTAS team for providing all the groundwork. So back to the organizers.
Thank you, Professor Shubhankar sir. I think it's a great feeling to be associated with this program and Endocrine Talk Show, and previously the Practice Pulse in Endocrinology during COVID, which we conceptualized under your leadership, going strong. And today we had more than 1,300 odd doctors, and that speaks volumes about the popularity of the program, and the physicians across the country would like to learn from the eminent panelists about the endocrinology. So thank you very much once again from our side at INTAS, and we are really indebted to all of you for coming on this panel and joining today, and making people learn about the link between kidney and endocrinology. So I would like to thank Professor Shubhankar, Dr. Bipin Sethi, Dr. Hemant Fatale, Dr. Harinarayan, and Dr. Rishi Shukla for being today and providing their words of wisdom to the doctors across the country. So thank you very much once again. This program came to you from the sponsors and makers of Dapawell and Ignalis M. So these are two products that we make, which are basically used in diabetes. You know that very well. So thank you very much once again from our side in INTAS, and good night to all of you. A very happy Mahashivratri to all of you. So thank you very much, and good night to all of you, sir. Thank you.
Thank you very much.
Thank you, sir.
Thank you very much.